So good evening, everyone. Welcome to the Africa Healthcare Network Fireside Chat Series number 210. My name is Dr. Amar Swali, and I am a consultant nephrologist and serving as the Director of Clinical Operations with AHN Tanzania. And it is my utmost pleasure to introduce a speaker who I proudly say I've been following his work for many, many years, and he's done an inspiring bit of work. His name is Dr. Abduzhappar Gaipov, and he is the professor at the Department of Medicine at the Nazarbayev University of Medicine in Astana, Kazakhstan. He is also the program director of internal medicine residency and nephrology fellowship programs, and also serves as a consultant nephrologist at the University Medical Center at the Nazarbayev University. He is an internationally respected nephrologist and associate professor. He's a globally published clinical scientist with 220 plus peer-reviewed papers shaping modern kidney care. He is also the co-author of one of the most comprehensive global CKD screening reviews covering about 83 countries and published in the Kidney International Reports. He is also widely recognized for his work in chronic kidney disease, dialysis outcomes, and population-level kidney health. He is also a former ISN regional leader and has contributed to nephrology education and research across emerging health systems. He is also a sought-after international clinical excellence, data-driven research, clinical policy impact. His research interests lie in nephrology, dialysis, and kidney transplantation, along with kidney injury and intensive care nephrology, apheresis and extracorporeal blood purification, and urinary proteomics and biomarkers of kidney disease, and also with clinical epidemiology, big data, and artificial intelligence in healthcare. He will be speaking to us tonight on the tubular toxicity of proteinuria and CKD progression. So, Dr. Gaipov, the pleasure I have had to introduce you is beyond words, and I'm really happy that you took this talk on short notice, and the floor is now all yours. Thank you so much.
Thank you very much, Dr. Amar, and good evening, my colleagues from Africa. Thank you very much for all organizers. Thank you very much for African Healthcare Network for organizing and for inviting me to this online webinar. So let me share my screen. So thank you very much again having me today. I want to today a little bit speak about the proteinuria and its tubular toxicity and progression of chronic kidney disease. As a nephrologist, we are always faced and we are always searching for the proteinuria in the patient's urine. So it's a very important topic for us. So my presentation will consist of some definition of proteinuria, clinical significance of proteinuria, pathophysiology, and some of proteinuria, tubular toxicity. And also, I want to also share at the end of my presentation some results of biomarker study in CKD patients. So as you know, normal urine protein concentration is usually less than 115. Even albumin is less than 30 milligram per 24 hour. And you cannot imagine that usually normal urine, we have more than thousands of different proteins. So usually we can say they are proteomes, and we can say also proteins, but again, they are not detectable. So their molecular weight is very low, and they usually not detect. So usually we can see even in normal patient only albumin, which is less than 30 milligram per day. So the most common proteins are the uromodulin, albumin, immunoglobulin, and when we can see in patients' urine, the protein concentration is between the 30 to 300 milligram per day. We usually call this albuminuria, and if the concentration of protein in the urine is over the 300 milligram per day, so usually we call this proteinuria. Why proteinuria matter? It's very important because the proteinuria has very clinical significant. It's very important marker because, as you can see, this is the marker of damage. This is the clue to diagnose of CKD, and this is a very well-defined risk factor of adverse outcomes, including kidney health, including kidney progression, even including the cardiovascular mortality. So Proteinuria is the effect modifier for interventions. As soon as we start to treat patient with nephroprotective strategy or even with immunosuppression drugs, we usually follow up the proteinuria. So if the proteinuria is less than, for example, 50 milligram per day during the 6 months, we can see complete reverse if so. So it's very important to look at the follow-up patients about the effective treatment. Also, the proteinuria is the surrogate outcome of the target of interventions in different clinical trials. So as you can see here, the CKD mortality has risen for 25 consecutive years. Proteinuria is the single most significant driver for progression. And as soon as we decrease the proteinuria, the 30% reduction of the proteinuria correlates with the 23% of decrease in the risk of end-stage kidney disease. So we, as a nephrologist, our strategy is early diagnose and early screen, and as well as early treatment of patients with chronic kidney disease. So another clinical significance of proteinuria or microalbuminuria is, as I already told, it's also related with risk of stroke, risk of myocardial infarction, risk of any other cardiovascular complication, as well as fatal complication. Also, as soon as we have proteinuria, we can see that patient graft is for transplanted graft is in the high risk, and also proteinuria is the risk for maternal and fetal complication during the pregnancy. And as you can see, the impact of proteinuria is very high in different disease. So the physiology of proteinuria is very complex and very difficult. So as you can see from this picture, so this is our nephrons, so this is our capillary walls. And as you can see in picture B, this is the glomerular basement membrane. So as you can see here is that you have 3 slices of the endothelium, basal membrane, and podocytes. So we have physiologic diagrams here, and usually all these glomerular basement membrane are charged with the negative charge, and albumin also they have negative charge, and usually big diameter of albumin they cannot go through this glomerular basement. So normally we have allowed in normal condition only 30%, 30 milligram of albumin, and they go through the first Bowman's capsule, and they will be reabsorbed by the proximal tubular epithelial cells. So as you can see, you have big 2-3 structures which protein should go through, and this is all of these are in normal condition. So if you are considering this in a deep dive for this proteinuria, as you can see, this is the proximal tubular epithelial cells, and in these cells we have megalin and cobalamin complex. So the megalin is the large transmembrane protein, cytoplasmic tail for the signaling and internalization. So as soon as albumin touch and contact with cobalamin and megalin, they make complex, and they will transfer the albumin to inside the cell. So as you can see, it is the epithelial cells inside the cell. They will ingest, so they will reabsorb albumin and they will destroy them. And some part of the albumin will be destroyed and autophagic inside of the cell, and some part of albumin can be just secreted again to the tubular lumen. So this albumin in normal condition is not toxic. So the main mechanism of the this megalin cobalamin complex is they just capture the albumin. So they also capture not only albumin, actually they also capture also medications and many other things. So one of the main reasons of the contrast-induced nephropathy is also the megalin. They capture the contrast media, and they mediates endocytosis and recycling these albumin cells inside these proximal tubular epithelial cells. So as soon as we have normal albumin at low dose, usually it is the low molecular weight proteins, so they prevent them loss from our urine, and then they reabsorb them. But as soon as we have high dose of protein, that means proteinuria, the system is overwhelmed. The issue that they cannot do their job properly, and they make issue for the toxins. So in the following future slides, I will explain the other issues. So if you consider the mechanism of progression, as you know, we have hemodynamic disorders. So we can say it is a hemodynamic mechanism of progression. We have autoimmune and systemic mechanisms which involved in the autoimmune complex disease. And one of the main reasons of CKD progression is the toxic and inflammatory effects. So that can be some infectious disease, inflammation, and toxic agents, some metabolic disorders like insulin resistance, lipid metabolism, and also obstructive nephropathies. These 5 mechanisms are the most important mechanism in the progression of chronic kidney disease. But if you consider the number of disease, so most of the patients from CKD is coming from the hypertension and coming from the diabetes. So, and most of them, they have hemodynamic disorders like hyperfiltration and intraglomerular hypertension. And most of the reason for proteinuria in daily, we can see in patients with hypertension and in patients with diabetes is the hyperfiltration. Of course, we have some specific diseases like glomerulonephritis, primary and secondary, and most of the reason for the glomerular disease, so for proteinuria, is the immune complex mechanism. So today we are not going to discuss about the immune complex mechanism of proteinuria. So what happens with hyperfiltration? What's the meaning of hyperfiltration? As you can see here is different disease which have same mechanism of hyperfiltration. In pregnancy, we have physiologic hyperfiltration. So as you can see, some focal segmental glomerulosclerosis, they also have hyperfiltration. And mostly it's diabetes and other hypertensive disease. So in diabetes, hyperfiltrations develop during as soon as we have high glucose number inside the capillary. As you can see, glucose is the osmotic molecule, and it lead to connect with the water, and it increase the pressure inside the capillary system. Because of the increased capillary pressure inside the capillary, they make the hyperfiltration and intraglomerular hypertension. Also in arterial hypertension, in hypertensive patients, we have some arteriosclerosis of the afferent arterioles, and it makes also inside the glomerular hyperfiltration. So that hyperfiltration lead to the damage of this glomerular basal membrane, and they can lead to the leaking of albumin from a huge amount of albumin from capillary system to the tubular system. So there is the factors leading to hyperfiltration, which is hemodynamic factors, afferent arterial dilatation, efferent arterial constriction, increased plasma flow. Also, as you can see, hyperglycemia, systemic hypertension, high protein diet, obesity. And so we accept that these conditions are very frequently in our population now. So in the first time, as you can see here, in normal patients without disease, there is a very low amount of albumin, and some amount of low molecular weight proteins are going through this glomerular basal membrane, but they immediately taken by the tubular cells, and they undergo to the lysosomal lysis, and they undergo to the recycling. But patient who has hyperfiltration or hypertension, so as you can see, the some albumin, it's more than normal, can lead, so they can go through the glomerular basal membrane, and not all of them are injected, so reabsorbed by the tubular cells, and some of them go through the other part of the endothelial tubular system. So in this case, we can say that selective proteinuria. But as soon as the number of proteins are very high, as you can see now, we may have high molecular proteins also going through the this 3-layer barrier, and also much amount of albumin and also much amount of low molecular proteins. So at this time, there will be overwhelm of the function of the proximal tubular epithelial cells, and they cannot absorb, they cannot collect, they cannot catch up all these proteins, and they will be overwhelmed. As soon as patient has a high level of proteinuria, which usually called nephrotic level, so the physiologic function which lead to the we can say detoxification of the protein, so they cannot do their job, and as you can see, the most of the protein they will lose from the tubular system. Usually we can say it is a well-known protein, urinary proteins, so albumin. So its molecular weight is 69 kilodalton. Transferrin. Usually we don't have immunoglobulin G. Usually we don't have complement C and fibrinogen. But as soon as we have glomerular basement damage, all these high molecular weight proteins can also leak from the glomerular capillary to the tubular system. So we should consider the different type of proteins in proteinuria. As you can see, we may see the pre-renal proteinuria. This is the when pre-renal proteinuria happens, when patient has a high level of proteins like immunoglobulin light chains. Patient may experience because of overloaded protein in the blood. They can go through the glomerular barrier, glomerular filtration barrier. Some proteins go through most of the case in the primary glomerular disease. It is the high molecular weight proteins. We call them the glomerular proteins. The glomerular proteins is usually coming from because of some immunocomplex disease or circulating immune complex. They damage the glomerular system, and they can, and also diabetes in the advanced stage of diabetic nephropathy and all other disease, they can lead to the glomerular proteinuria. Also, we can face with other, we call tubular proteinuria. So the reason for tubular proteinuria is the inadequate reabsorption of filtered low molecular weight proteins. So actually, tubular cells, they cannot reabsorb all proteins. And also, we may have loss of protein from tubular cells. And also, we may have some protein, which is post-renal protein, coming from the lower urinary tract proteins. So reason for them is, as you can see, pre-renal proteins, they usually coming because of the increased synthesis of low molecular weight proteins. And then this is some example of markers like protein of Ben-Jones protein, increased total protein. Selective glomerular protein is coming because of the increased glomerular permeability to low mol. So it's like albumin, transferrin. And as you can see, another examples of, for example, non-selective glomerular proteins. It's almost albumin, immunoglobulin A and G. And tubular proteins, it can be alpha-1 microglobulin, beta microglobulin, and others. And the post-renal is also beta-2 microglobulins, apolipoprotein A1 and EGA. So what happens as soon as we have continuous proteinuria? The protein will make the toxicity for the cell. So I will explain in the next slide. And as soon as protein, the huge amount of protein is not circulating, is going through the tubular system, they will lead to the tubular atrophy. They will lead to interstitial fibrosis. And that's why patients with proteinuria, they can immediately progress the chronic kidney disease progression. So our team with my PhD student at this time, he's now postdoc with Dr. Jalal Mahamajanov, and we created this paper, and it was recently, 2 years ago, published in NDT. So we considered all biomedical reasons of protein toxicity. So we considered these big four mechanisms of toxicity of proteinuria. And then so I don't want to stay in this slide because it's very complicated. So to make them easy, so I created a different other other slides you can. So the main molecular pathway for the proteinuria is the toxicity of albumin-bound fatty acid, because albumin not by itself. So you know the albumin is also binding with different medications and different fatty acids, and then that's why not only albumin by itself, because albumin is the carrier of the different. It's the carrier of the different molecules, also toxins, also fatty acid, and why? And because of that, it's inside the tubular cell, it makes his toxicity. Another molecular pathway is the oxidative stress and the mitochondrial collapse. So mitochondria is the energy of all cells, and as soon as we have overwhelmed proteinuria, there will be collapse of the mitochondria. The second mechanism, the third mechanism coming is the impaired autophagy, because you know the autophagy is the mechanism that they usually clear, so they are cleaners, so they clear the all died cells, because we have a lot of died cells inside the tubular cells, so it will be impaired also. And also endoplasmic reticulum stress and complement attack. So this part is mostly related with the immune mechanisms of proteinuria. So what happens? So as you can see, we have megalin, and so megalin catches with cubulin, they catch the albumin. So albumin, they are carrier of the different elements. As soon as they catch them, so they take them inside the cell. As soon as they go through inside the cell, they are unpacking this albumin. So when they unpacking this albumin, there will be lysosomal degradation release. And also, as soon as the high number of albumin, they have a high number of free fatty acids, they also release. And the free fatty acids, they initiate the secretion of the ROS, and then they started to damage the mitochondria. So what happens? The front phase is as soon as fatty acids infiltrates inside the mitochondria will overload, and they will damage, and electron transport system and the beta oxidation are overwhelmed. And then the mitochondrial membrane will lose their charge, and it releases cytochrome C. And cytochrome C leaks into the cytosol and then release capstone 9 activation, and they will activate apoptosis. As you know, apoptosis is the die of the death of the cells. So as you can see, the many mitochondria and epithelial cells will lead to the apoptosis. As soon as we have apoptosis, these death cells supposed to be autophagic by the macrophages. Because of this overall proteinuria and protein reabsorption, there will be, because of the high level of free fatty acids inside the cell, mitochondrial system is completely go to the dysfunction, and they activate the NOx activation driven by albumin, and there is the RAC1 cells, RAC1 enzymes, they activate the NOx activation. And then they will lead to the inflammation as from P38 MAPC pathway. And then they started to release also NOS. The second part is the autophagy. So in the first stage, like compensation or resilience state, autophagy happens. They try to clean all died cells, but then they also get overwhelmed, and then they will stop the autophagy. And because of they stopped autophagy, there will be many persistent overload activated mTOR cells. And then this leads to activation of so they will by themselves poison some mitochondria and other cells. And then happens lysosomal membrane permeabilization because of high number of radiated oxygen substrates. They will lead to the lysosomal damage, and high number of catepsin will release. So because of, again, overload proteinuria, massive proteinuria increase the lysosome count, but decrease the enzymopathic activity. And then leakage of acid and enzymes triggers immediate, they lead to the necrosis, and again, they increase the apoptosis. Another issue is the endoplasmatic reticulum. as soon as the protein overload increase the intracellular calcium and radiated oxygen substrates, also endoplasmic reticulum will has their inflammatory stress. This mechanism is mostly not related with diabetes or hypertension, but is the most important part when the glomerular system, they leak for immunoglobulins and or other immunocomplement activation. So they usually absent in the urine, but as soon as we have glomerular damage because of some glomerulonephritis, EGM, membrane nephropathy, so they will go inside to the tubular lumen, and they will also damage by membrane attack complex. So they're making membrane attack complex, and they are making the hole inside the cells. And this is another factor why our glomerular patients, they have faster getting to end-stage kidney disease compared to other CKD patients. So because of this leak, it will be activated immune attack, and by immune antibody, they will damage the all tubular cells. So in the first stage, so our normal proximal tubular endothelium cells, they will transition to some myofibroblast and fibroblast, which makes the lead to the nephrosclerosis. And also they activate the inflammatory factors, and then they lead to the increased production of fibronectin, alpha SMA, and then they lead to the increased fibrosis and leading to the nephrosclerosis. So this is like a normal cycle of glomerular disease. So as you can see, the proteinuria, which make to the overwhelmed peritubular, so they will dysfunction for the megalinocubulin system, and then they lead to the inflammation and fibrosis, and they lead to the also loss of the nephrons and increasing strain of the remaining nephrons. And all of this, this is the main mechanism of nephrotoxicity of proteins. So the main mechanism is energy crisis, waste autophagy, endoplasmic reticulum stress, and the complement activated inflammation inside the epithelial cells. So what's the important nephroprotective target? So in case of diabetes, as you can see, ACE inhibitors, they are leading to the decrease inside the glomerular hypertension. Also SGLT2 inhibitors, they also lead to the decrease the inside the capillaries, intraglomerular hypertension and hyperfiltration. And also, as you can see, non-steroidal aminocorticosteroids, they decrease the inflammation, and also endothelium receptor agonists, they also consider to decrease the fibrosis in the epithelial cells. But all these nephroprotective medications are directed to decrease the hyperfiltration and intraglomerular hypertension. But here we are not talking about the immunosuppressive medications, because immunosuppressive medications, their effect is a little bit different. So they affect only targeted for some immune complex diseases. There might be also some interesting thing, because as we told that protein albumin is not going inside the cell by themselves. It also captured some free fatty acid, and maybe there might be some different therapeutic targets to decrease the number of fatty albumin comparing to the non-fatty albumin. So this is the different new hypothesis. So maybe we should work on that. Now I want to just give some clinical example from my patients. So of course, we already told that healthy kidneys, they excrete more than 1,000 protein, but again, not all of them are detectable in normal hospital settings. So we know only about the albumin and the protein. And then, but these proteins can be not only pathogenic proteins. Some of them can be like biomarkers, and it's very important. So just imagine, so you have two patients, same age, approximately same disease, approximately baseline same GFR, and then approximately one of them has not high protein, but second one is the low protein, high protein. So in my experience, I have different same clinical setting, but at the end, one of the patients, they CKDs progress very fast. As you can see, for example, even this patient has the 2.2 proteinuria, and then despite the treatment, the patient has very fast decline in GFR. But for example, I have one patient who has also high proteinuria. Despite the proper treatment, patient still keep the GFR in the normal range. So the clinical question was, why are the different outcomes with the same risk factors for CKD progression? Have you had any patient in your practice who CKD progressed rapidly despite low proteinuria, while some patients with high proteinuria responded better to treatment and CKD did not progress? And probably there is the related killer proteins, not only albumin that we know, maybe different type of albumin or maybe different proteins which have significant tubular toxicity toward the epithelium of the glomerular tubules. So that was the hypothesis why there might be different outcomes having the same risk factors. So this is very important to know. Maybe we have not only albumin, maybe there is something, for example, like fatty albumin or not fatty albumin. So we don't know. So to do that, so we created this clinical question. Why does similar proteinuria lead to CKD progression differently? Maybe we should study the compositions of the urine proteins. So is there any job done before? So we make all this, we asked all these questions, and we created some proposal for the grant. And we started to do some proteomic analysis of our patients. In the first stage, we just wanted to make proof of concept. And in the second project, we started to use identification and validation of urine protein biomarker in glomerular and diabetic kidney disease using proteomic setting. So in the first stage, we just make some pilot study. During this pilot study, we identified some proteomes. As you can see, for example, this patient, they have different around 300 different proteins in the urine. So when you use high performance mass spec, when we use this high performance liquid chromatography mass spec, you can identify more than 300, even more than 1,000 different proteins. And we were able to differentiate, for example, this healthy urine, urine from the healthy patients and urine from the nephrotic patients. As you can see, there is a different, as you can see there, they have like same albumin, but the red one is the patients with albuminuria. They have different other invisible proteins in the urine. So then we can detect using the proteomic study. And in the last stage, in the second stage, we little bit extended the number of patients. As you can see, patients with this is the control group, CKD stage 1, CKD stage 2, CKD stage 3. And the heat map analysis showed that patients with CKD stage 3, they have different appearance of different proteins in the urine compared to the healthy control. As soon as we have advanced stage of CKD, we have plenty number of proteins coming through the urine, and it is detectable. All proteins are. But again, this is the initial stage. We still not finished our research. Now we have to a little bit extend the number of patients, and we have to test our hypothesis, and we have to identify. For example, we have preliminary, for example, vitamin D binding protein, phytune alpha, and some other proteins are significantly showed high in the CKD patients. So we have to extend our research and make it. So we are still working on that, and we are searching some biomarkers which related with adverse outcomes in patients with different type of proteinuria. I have finished my presentation. If you have any questions, we can discuss, and I try to answer your questions.
Dr. Gaipov, thank you for that truly illuminating discussion. And I believe you have challenged all of us to, sort of move beyond viewing proteinuria as just a, passive laboratory result, and instead sort of recognize it as an active mediator of injury, not only accelerating tubular interstitial inflammation and fibrosis within the kidney itself, but also the sort of multi-organ systemic endothelial dysfunction across all these organ systems. I particularly enjoyed the part where you emphasized on tubular toxicity, particularly the role of the proximal tubular overload, those inflammatory signaling cascades, the maladaptive repair. It reminds us that CKD progression is driven as much as tubular biology as it is by glomerular pathology. And it really shifts how I think about an early detection, how to therapeutically target, and in the long-term renal preservation of the patient's kidneys. So thank you for reframing proteinuria as a pathogenic driver, but just not just as a prognostic biomarker. I would like to start with the first question on a personal level, and given, as you rightly pointed out, all these therapies, emerging therapies that we have had with the they reduce the proteinuria through the hemodynamic mechanisms such as the RAS blockade, as you pointed out, and the SGLT2 inhibitors, as you also pointed out. Do you believe that we are sufficiently targeting the intracellular tubular inflammatory and fibrotic pathways triggered by this protein overload? Or do you see a future where sort of some direct anti-inflammatory or anti-fibrotic tubular targeted therapies would become necessary to truly alter these CKD trajectory?
So I hope in the future there will be different targets, as you told. But currently, the most of the nephroprotective agents, they are directed to just decrease the number of proteinuria through the eliminate the hyperfiltration and intraglomerular hypertension. So SGLT2 inhibitors, yeah, they have, for example, RAS inhibitors, they have like primary nephroprotective effect. But SGLT2 inhibitors, they have same effect as the RAS inhibitors, but they have also different so secondary effects. So the first thing is they try to so they block the SGLT2 receptors, and they lead to stop the reabsorption of the glucose. So as soon as they stop the reabsorption of the glucose, there will be not overwhelmed tubular cells. So they decrease the function. So they decrease the how can I explain? So they decrease the work of the epithelial cells to reabsorb what? To reabsorb the glucose. So that's why they save the energy. So they save the mitochondria. So that's the second effect of the SGLT2 inhibitors. But again, based on the different type, because we have only detectable albumin only in the clinical settings. As there is also ongoing different studies. There are also many studies. They are doing not only proteomics, they are also doing some lipidomics. So in my presentation, I told about the like fatty albumin and not fatty albumin. Maybe we should also consider the like target treatment for this these lipidomics that can be detected from the proteinuria from the urine. So I think in the future we will have not only nephroprotection directed to the hemodynamic mechanism, but in the future there might be also some targeted treatment for the eliminate the albumin, which is like bad albumin from the good albumin. So
yes, we hope so too. I see Prof. Bhima in the audience, and he has his hand up. Prof. Bhima, please unmute yourself.
Thank you very much for that, and thank you very much, Dr. Abduzhappar, for that wonderful presentation. My question is very simple. It's more a lack of understanding rather than anything else. What's the impact of pH on the tubular proteinuria?
pH, can you explain pH?
I mean, acid-base balance, right? So if you're,
okay.
If the urine is more acidic or alkali.
So in normal patient, so they don't have proteinuria. So even if they have low pH or high pH, it doesn't matter.
Yes.
But high pH, I think they lead to the degradation of the proteins. So they just degrade. And then, maybe this is the matter in patient who has high proteinuria. So acidic urine, they lead to the immediate degradation of the protein, so they are acidic. So maybe a high acidic environment for the protein that I don't answer correctly, but in my opinion, they lead to increase the toxicity, protein toxicity.
So the reason I'm asking is that it might impact your measurements. You know what I mean? So that may be the problem. See? But thanks.
Thank you, Professor Bhima. Please feel free to raise your hand if you have a question for Dr. Gaipov, or probably you could just write it down in the chat box. I have another question for Dr. Gaipov. That how much would you now advocate for kidney biopsies in patients with a bland sediment in the urine?
So usually there is an indication like primary indication for the renal biopsy, and there is the so secondary or we can say relative indication for the renal biopsy. So as soon as we see the proteinuria, and if this proteinuria is, for example, low proteinuria, we consider it might be like tubular proteinuria, or so, for example, proteinuria is less than 1 gram per day. In case if it's persistent, of course, we do biopsy. But if you can see, we can decrease the proteinuria by nephroprotective drugs. So we cannot consider, for example, for renal biopsy. But sometimes independently from the number of proteinuria. So in some case, if you don't know why the creatinine is elevated, for example, why the kidney function is decreased, if you have the normal size of the kidney, so it is the consideration of the another consideration indication for the renal biopsy. Most patients with another epithelial cast or different casts, so if you don't have proteinuria, we don't consider renal biopsy.
Thank you very much, Dr. Gaipov. We have one question in the chat box from Dr. Lloyd, and he's thanking you for a wonderful session, and also asking, tubular resilience is seen to vary between individuals. So is the tubular toxicity of proteinuria quantitative, qualitative, disease context dependent, or a combination of all of the above?
I think the most important thing is the quantity of the protein and the quality. Because I have one patient which is steroid independent nephrotic syndrome, and he's around 20 years has proteinuria and never became to end-stage kidney disease. Even he has a very high number of proteinuria, and of course patient always decline for renal biopsy. He never done the renal biopsy before, and we still encouraging him to do renal biopsy, but he is declining to do the renal biopsy. But I just surprised because he has like persistent proteinuria around 1.5 and 2, and we're trying to manage them with different medications because we don't know biopsy. But the patient didn't develop end-stage kidney disease. That means maybe not the quantity here. Maybe it is the quality of proteinuria is different. But the important thing is the quantity, because we know that most of the patients with high proteinuria, they have immediate decline kidney function, or patient with even with low number of proteinuria, like around 0.6, 0.7, or around 1.0 proteinuria. But if it's persistent proteinuria, they will develop end-stage kidney disease maybe in 2, 5, or 10 years. So both of them, even the first thing is the quantity, and possibly second part is the quality. But we don't know about the quality. We are trying to work on this direction.
And I see Dr. Lloyd has his hand up. I don't know if it's for the same question. Dr. Lloyd, would you like to unmute yourself? Dr. Lloyd? While we're waiting for Dr. Lloyd, maybe I'll just throw this one out there. Yeah, so as we know, the albuminuria has been added to the CKD, to the CKD staging for the KDIGO classification of CKD. Do you think tubular proteinuria would be added or would be considered to be added into the classification in the future?
No, I think it's not going to be, because we don't know exactly which is tubular. So there is no measure. I mean, we can measure using the some mass spec, but in normal clinical setting, it's not available yet. Possibly in the future, if someone for example, if someone develops tool to identify the tubular proteinuria from glomerular proteinuria, then possibly yes. But I don't think in the maybe in the near future. But but now it's not possible to say it is like tubular proteinuria. It is not tubular proteinuria. We test relatively just based on the clinical settings. But again, it's supposed to be measured exactly.
So, Dr. Gaipov, this is a recorded session, and we do post this on YouTube. So, for anybody who's probably missed this session, we could probably share a recording with you, and you could circulate it within your circles, and it will be published on our YouTube channel for posterity.
Good, thank you.
Dr. Gaipov, on a personal level and through AHN, I would like to thank you for sparing your time, your important family time with us. I understand it's quite late for you in Astana. I also hope you will not say no to a future talk with us on another interesting topic. We hope to host you again very soon. And for all our attendees, Dr. Yuri has posted a CKD link for Tanzania and Kenya in the chat. So please do use that to access your CKD, your CPD points. And with that remark, Dr. Gaipov, thank you so much for joining us tonight.
Thank you very much, Dr. Amar, for having me. And it's my pleasure to speak anytime. So thank you very much.
Thank you so much. Thank you so much, everybody, for tuning in tonight.